Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 20. In this week's Coffee with Consultants feature, my guest is Professor Laurel Baldwin-Ragaven, a professor in the Departments of Family Medicine and Primary Care at Wits University, as well as the clinical head of family medicine in the Southern Districts for the Gauteng Department of Health. Professor Laurel graduated from medical school at McGill University in Montreal, Canada in 1983, and after a career in medicine spanning almost 40 years, is now focusing on more non-clinical work, such as on the social determinants of health and advocacy. Not only has she worked in higher education and training of medical students and doctors across 3 continents, she's also a human rights activist and an accomplished researcher and academic with dozens of publications and hundreds of citations. One of our previous guests, Professor Adam Mohammed, suggested Professor Laurel as an interview guest, and I'm so glad he did. This episode is slightly longer than some of our other episodes, but I want to encourage you to keep coming back to it if you need to, in order to finish listening to the whole episode, as this really is one of the most impactful interviews I've personally conducted. I strongly believe there's something for everyone to take home from the wisdom and insights shared in this episode, so it really is my privilege to bring it to you through this podcast. Before we dive into our interview, let me take a moment to tell you about our partners on today's episode. Aestheticos Portrait Studio is a photography studio based in Sandton, Johannesburg. Aestheticos offers newborn and baby photo sessions that are baby-led, non-posed, and result in beautiful portraits of your baby. They also do professional portraits and headshots, so if you're looking for an upgrade for your professional medical practice, LinkedIn profile, or social platforms, check out their website aestheticos.art or find them on Instagram with the username @aestheticos.studio. Both of these are available in the show notes for this episode on whatever platform you're listening on. They have affordable rates for the professional work you're going to get, and on top of that, you can quote Dr. Coffee when making a booking with them for 15% off your portrait package. Our second partner on this episode is Direwolf Financial Services. If you watched or listened to episode 17 of the Dr. Coffee podcast, you already know that Direwolf is all about protecting the practice and providing tech-driven financial services to medical professionals. Direwolf have given listeners of the Dr. Coffee podcast free access to their helpful online curriculum of courses. These courses feature legal and medical experts presenting on topics such as understanding medical negligence, informed consent, disclosures and record keeping, and what to do when you're sued, amongst other subjects. The courses are HPCSA accredited and will provide you with up to 16 CPD points for completion. All you need to do is register for the courses using the provided Direwolf voucher codes, which you can receive by visiting www.direwolf.co.za/Dr. Coffee. And now, without any further ado, here is Professor Laurel Baldwin-Ragaven. Welcome to the Dr. Coffee podcast, Professor Laurel Baldwin-Ragaven. Thank you for agreeing to be on the podcast.
It's a pleasure, Simon. Thanks so much for having me. I really am grateful to be here.
I'm really humbled whenever I have heavy hitters on the podcast, and I'm so glad that you accepted the invitation. Prof. Adam Mohammed raved about you. So no pressure, but thank you for coming on. You're going to be speaking to us primarily about what it's like to be a family medicine physician, but I would also like for your role as an advocate for patient rights and all of your wonderful experience in the publications to come through. So let's just quickly dive in with our first question, which I'll ask every guest, which is, where did you do your medical training?
Okay.
And so we'll go from there.
All right. So, Simon, I started medical school in 1979 at McGill University in Montreal, Quebec, Canada. And I'm not Canadian.
Okay.
So that was my first international foray. In North America, and this is really just background for listeners, that medicine is a postgraduate degree. So medical school is actually 4 years, but you can't enter medical school without an undergraduate degree, which is also 4 years. So prior to that, I was at Smith College in the United States, which is one of the Seven Sisters, when women were not allowed to enter higher education, universities. Colleges and universities like Smith opened up. And this was an undergraduate liberal arts college, but it was the same thing for medicine. So Women's College of Pennsylvania was the first college or medical school to admit women.
And this was in the 70s. I mean, that's not so long ago.
No, it isn't that long ago. So I graduated high school in 1974. Now you know my age. And then went to Smith straight away. And because I always knew I wanted to do medicine, but approach it from the politics of health and really get into why some people get sick and why other people don't. And I think a lot of that was around what I saw growing up as a child and these inequities and disparities, which I didn't really fully understand, but I thought that I needed to understand that before training as a medical doctor, and saw medicine really as being a very problematic field. So I think I was going in with the spirit of a reformist anyway. So I majored, and being someone who is, I think, by personality interdisciplinary, majored in the first interdisciplinary degree that one could have as an undergraduate, which at that stage was American Studies. So I took a mixture of politics, sociology, literature, and all of the first 2 years of medicine. So organic chemistry, inorganic chemistry, human biology, physics, calculus, all of that as well. So I carried all those, and then was also at Sussex University on an exchange fellowship in English, in the School of English and American Studies. That was NGAM. And that's important because I think that sort of marks my relationship with South Africa, which really started out as a love story in 1976. So when you ask me where I went to medical school, I was already an older student. In the inverse of the WITS program, we were a class of about 170, which was one of the largest classes at that time. And again, just continuing the story about gender, we were only, I was trying to calculate this, we were less than a quarter, we were about 23% women.
Wow. So out of that 170?
Yeah, we were about 40.
Sure.
40 women, about 25 Americans. And there was a very small number of what they called Med-Ps, which would be the dominant entry group in South Africa. And these were young people who had graduated high school and then done 1 year of a sort of pre-med program and then joined us. Or actually, it was 2 years of a pre-med program and then joined us. So in my class, and in fact, one of my classmates, who had a PhD in physiology, and his wife, who was actually our consultant in pediatrics, and they ended up getting together during our peds rotation, and I was at their wedding in 1985. At any rate, they have the means. They're both retired now. They became incredible. She was always a pulmonologist. He became a cardiologist, and they ran CHOP, which is the Children's Hospital of Pennsylvania, the heart and lung transplant. So McGill was, it was an interesting choice, and I felt it was not terribly progressive at the time. Our curriculum, of course, Sir William Osler was there, and we have the Osler Library of Medicine, and his image photograph dominated our lecture theater, and our curriculum was really based on sort of 19th century Scotland at that time. So very formal, very memory focused, and having come from the social sciences, that was a huge transition for me. So Yeah, so in the middle of that, sorry, I think this is an important thing because what do people learn from failure? The first time I had applied to medical school in 1977, I did not get in. I had a number of interviews, and people were not convinced that someone from the social sciences, with this American Studies degree, they said, well, you're very interesting as a candidate because the interview, rightly or wrongly, is a big part of medical school admissions in North America. And they basically said, but we're not sure you can do the science. We're not sure you can handle the science. So at that stage, I said, okay, you're not sure that I can handle the science, then I'll go and work in the sciences. So I actually worked at NIH, the National Institutes of Health, in what was then NIA-MDD, arthritis, metabolic diseases, digestive disorders, in the lab of genetics and biochemistry.
Wow.
So at that
Challenge
stage,
accepted.
Yes, exactly. Challenge accepted, and I was accepted to 5 different medical schools.
Amazing.
Yeah. So for a lot of different reasons, ended up transnationally in Canada, in Montreal, which is, and I ended up spending probably about 16 or 17 years there.
That's amazing, Prof. So you obviously then went through medical school, and
Yes.
then how does your internship or junior doctor's years work over there? Were you associated with your university
Yes.
hospital, or?
So that's an interesting question because right around the time that I was graduating, they had, I think it was on its last legs, that you could do a rotating internship. So you could either do a specialized internship, so 6 months of medicine, 6 months surgery, or you had the option of doing a rotating internship. Or you had the option of entering directly into your specialty of choice. So right out of medical school, if you knew you wanted to be a surgeon, you would enter a general surgery internship, which counted towards your registrar or resident training. So I felt as kind of an older doctor at that point, and we were married in my first year of medical school.
Yes.
So that was 4 years after I did meet the love of my life, and I felt we wanted at some stage to start a family, and it was just time to get going into some kind of specialty. And because having had that undergraduate degree, all of these different experiences,
You already had a mission.
Yes. And I think that's really important, and when I was thinking about what I might talk about, it really is trying, I think, Simon, to find that mission, or at least the principles, the foundational sort of compass that will help to guide you when you are confronted with all of these different choices. So I think mission, maybe not the exact pathway. I'm not saying that, but I really am saying that you need to figure out the principles that will guide you in the myriad of decisions and choices that you have to make along the way. So I actually wanted to be, they were just doing limb reattachment, at that point. And I think what's fascinating is you stay in medicine long enough, you things that we take for granted, there's a history to each one of them. They didn't exist before. So now, in a way that we're living in a kind of post-COVID world, we take it for granted that there are pandemics. Otherwise, none of us was alive at the time of the Spanish flu pandemic. But yet, we can't imagine a world now without something like the devastation of COVID.
That's such a deep and interesting thought. Like, if you were to go back and speak to Osler about diabetes and treat it with insulin, we take for granted we're literally prescribing insulin on a daily basis in the wards. And this is a life-saving medicine that was only invented 100 years ago.
So, so in my long career, I feel incredibly privileged and blessed to have those experiences around something even like the Cochrane, for example. So we were having
reviews,
the Cochrane. It used to be called the Cochrane collaboration.
Okay.
They do put out these reviews,
Yes.
but it started out in a way as a challenge And by Professor Cochrane and Ian Chalmers from the UK, who's now Sir Ian Chalmers, took up that gauntlet in a way to develop consistency and and kind of a rationale for why we do what we do, because before that it was by eminence. So if you were the professor living in Cardiff in Wales versus the professor living in Montreal versus the professor living in South Africa, there was no common ground as to what you did. And so things like the Cochrane reviews, meta-analyses, systematic reviews, those are actually very recent in terms of bolstering whatever intervention we do, the histories we take, the kind of physical examinations we do, the investigations, to develop some kind of common ground. And we do that because it works, and because
I hope the
it's
medical
cost.
students listening to this episode
Yeah.
appreciate what you're saying, because we overlook the importance of the education we get in research and how to do good evidence-based medicine. It's almost like an aside, or
Yes.
a project that we do begrudgingly. And then when you listen to the specialists and they talk about how important research was to their development as a surgeon or as a physician, and their day-to-day practice,
Right.
which is saying is so important, that this is not something that's been around for 200 years. It's
No.
something that's new.
It's very recent. It's, it's not even really 30 years old. I mean, I think the ideas predated that, of trying to justify, to provide the evidence and justification, not because it worked with Simon, or not because it worked with Laurel, or not because it worked with Nomfundo, but because it works on, thousands, tens of thousands, or a million people, and all different kinds of people. And this is where sort of inclusion and exclusion about who gets enrolled in clinical trials. And so I mean, these again bring up questions of equity about, who is medicine for? Because before that, it was like choosing your church. I want to go to Dr. X because, he resonates with me and I believe in his spirit, and no, I'm going to go to see Dr. Y because this is what Dr. Y does. And I mean, there is still some of that now, but there has to be sort of certain minimum standards that we all benchmark ourselves and against, and clinical practice guidelines, which is a key part of family medicine.
Yes.
Okay. So coming back, I'm bringing myself back here.
Love that. It's almost like pains me to bring you back to your development and your training.
Yeah. So I didn't do an internship, so I bypassed that sort of...
By choice, you chose this is what I want to do.
Because that and in the end, in Canada now, everybody has to go through a residency or a registrar training practice in family medicine in order to be able to become a general practitioner, a GP or a family physician. So there's no non-general practice option except for doing postgraduate residency training in family medicine.
So I have a question related to that. So in South Africa, people can locum in a GP practice. Basically, once they've finished their ComServe, they can go work in a GP practice. If I understand you correctly, you're saying that overseas, if you want to call yourself a general practitioner or you want to work as a GP, you must have actually specialized.
This
as
is
a
in
GP.
Canada, yeah,
Okay.
and actually in the UK, where they don't have a title called family physician, but you have to go through a formal GP training program. Postgraduate, if you want to practice as a GP or even do a locum in a GP surgery.
So in South Africa, where we have people who have done 2 years of internship, which is a structured program, you've gone
Correct.
through all of that exposure, some of which is in primary care for 6 months, and then you do your ComServe and
that's recent, by the way.
Yeah, that I do understand.
Yeah.
That's recent. And then you do your ComServe, and that could be, at a big center, or it could be at a district level, it could be out in rural. Do you think that our junior doctors are adequately prepared to be a general practitioner? Is it fair to say that our 3 years of junior doctor years makes up for?
So I have to be very careful what I say here. And I've despite this international experience, I've been in South Africa. I've been at WITS now for 11 years. I was at UCT in the 90s and in the early 2000s. So I guess what pains me in some ways is that not enough recent graduates, junior doctors are actually going into general practice. And I understand that it's already you guys, it's a very long, arduous process, 6 years of medical school, 2 years of your internship, 1 year of community service. And if you enter as a graduate, you think, well, am I really just going to do all of that, just to be a GP?
Everyone says just.
That's what, yes, and I'm emphasizing that. I've said that for emphasis. So I have to be careful, because then if I talk about, well, if everybody then needs to go through a 4-year registrar training program in family medicine on top of that, I think it becomes a very long journey and a very long road. And the other thing that I think is important in South Africa, we still don't have this common understanding of kind of one family, one doctor. And a doctor in South Africa is an incredibly scarce resource. Not to say that even in first world or the global north that access to general medical care is easy. It isn't. There's shortages in primary care doctors almost all over the world. And I think people may be familiar with the UK experience that's poached a number of doctors from so-called third world countries because they're not graduating enough of their own practitioners. So international medical graduates often go into general practice, and for different reasons than here in South Africa. But, I think that we don't, and I think the kind of on the so-called consumer side of this, even though people may want to have their own kind of house doctor or family doctor, it's really been very few people who can access, that level of service. And what we offer the majority of South Africans, is really kind of a clinic, a sister of some kind, a nursing sister who may or may not have had primary health care post-basic training. So I think that tragically, as we were kind of talking about before, especially how important prevention and health promotion and early detection of any condition is in terms of decreasing morbidity and mortality, that we rely heavily on frontline healthcare workers who are not medical doctors. So, it's until we get a kind of unified health system that has as its primary goal to serve the entirety of our population and not just a few in very different ways, we don't have a single standard of care or a kind of health system that caters equally or equitably to everyone who needs our services. So I know it's a long roundabout argument. No,
I've had so many guests who say, "Oh, I'm so sorry for that long answer to a short question." But the questions that we ask on the podcast are always open because we want to get your expertise on. You'll answer in a way that unpacks so much more to our audience. So thank you for that. So family medicine then, do you see that as part of the solution, or is it the way the system sets up kind of hampers the role of family medicine physicians in a way?
So I think, I think there's truth in both aspects of what you're saying. Family medicine is absolutely part of the solution because we are the specialty of generalism. And I don't think you can learn everything, in coming out as a minted family physician, given our current training situation in South Africa, I don't think you can come out with what the registrars graduate with after 4 years doing specialty training in family medicine. So what I was really talking about, I think, is that the power and the privilege of, in the first instance, being a medical doctor in South Africa. And I don't think people necessarily exploit that to the best degree that they can in terms of being advocates for the health of our entire population. I think it's exploited perhaps for different reasons. And it's hard to generalize in that answer, but I definitely think that in our training of registrars in family medicine, we do a lot around leadership and clinical governance, and sort of stepping into that power that innately, in the privileged position that we are in, that we leverage that to improve our healthcare system from the ground up. And I think rather than top down, the positionality of family physicians in sort of the medical and the healthcare food chain puts us at the coalface, and puts us in the district, not only in district hospitals. And this was a big debate, amongst colleagues in Gauteng and nationally about, where do family physicians, where is their best location? And, my own positionality on this is that, in my own training and kind of worldview, is that we need to be as closest to the people we serve. And whether that means walking door to door, and I'm not saying every day, but with community health workers and visiting people inside their shacks and going into hostels and formal and informal communities, I think that's where we need to be, or at least have sight of that.
Yes. So as you're speaking, you're describing a role of family medicine physicians that for some people they'll say, okay, I don't want to be involved with that, but there will be listeners who go, oh my, this is exactly what I resonate with. This is why I wanted to get into med school in the first place. This is why I wanted to be a doctor.
Sure.
Do you think that somebody who wants to be an activist, somebody who wants to be politically involved, somebody who wants to make a change on a district level, on a national level, somebody who aspires to one day be a minister of health, do you think that family medicine is the right path that they should go in?
So that's again, I think that's a hard, of course, I think it gives you a lot of opportunities. I think in South Africa, because it is such a young discipline, it only became a member of the colleges as a specialty in 2011. Well, actually, that's when the registrar training program started. So I think you can be an activist and an advocate for change in whatever specialty or in general practice that you want to be. So, for example, at UCT, there was a highly qualified pediatric plastic surgeon who decided to get very involved in one of the problems that he was seeing, and this was shack fires, unattended shack fires. And some of your listeners may know this, but he developed a small stabilizer, which they call the turtle, in which you could put these informal tins in that people were actually making fires inside on these cold, damp winter Cape Town seasons, and that actually, because what had happened is that very often these would tip because they weren't stabilized, and then he would see. So he went upstream. We talk about in public health going upstream. So similarly, I think there are family physicians who enjoy practicing aesthetic medicine, doing chronic care, who don't venture out into the wider community, but who are quite content. And it's a very admirable practice, too, of doing it well, looking after your 3,500 patients that form part of your panel, and looking after them from cradle to death.
Yeah, from womb to the tomb.
From womb to the tomb, yeah. So I think it really depends on whether advocacy or activism or being a kind of reformer, you will see this in whatever area of medicine that you practice in. But of course, being a family physician for me has given me the platform to do both. Because I think I started to go off on a tangent around limb reattachment. And I thought that, okay, so I'll become like a microvascular surgeon, because that also kind of suits my personality a little bit, of reattaching hands or, limbs and microsurgery had just come into being then. And really, like, I thought that was a phenomenal kind of breakthrough, and being a woman pioneer in surgery anyway, because there were so few of us, even as students. There weren't very many role models or mentors. So I thought that could be an interesting field. But then I thought, it would be too restrictive. And so for me, I think in family medicine, it's given me the opportunity to look after people with continuity of care, to form deep relationships. I'm still in touch with many of my patients who I started to see even as a registrar in 1980, in 1983, 84. That was just the beginning of AIDS. We talked about that as well. So in medical school, I saw the index patient in Canada.
Wow.
He was admitted to the Royal Victoria Hospital, and we all had to don, and shield and everything to see. We didn't know.
Transmission.
We had no clue. No, he was an airline steward. There's been a lot written about him for Air Canada. But we were in his room, he was very personable, allowed us all to examine him, feel his lymphadenopathy, look at his Kaposi sarcoma, which again, it was kind of an undefined rash at that point that nobody had really named. And it's those associations that we all take for granted now. So I have had that ability of continuing to be in contact with those patients even now, less of course because I'm living here, but on Facebook and sometimes through messaging, still asking advice.
I think what's great that comes through, and this is why I asked the question the way I did, is because you clearly want doctors to be leaders in their community and to be advocates for patient rights. And sometimes somebody will say, oh, well, if you want to do that, you can only do it within your sphere of influence.
Yeah.
You're describing, on one hand, family medicine, and on the other hand, microvascular surgery, which to an untrained or inexperienced eye might seem worlds apart. You're going down completely different career trajectories, and yet you can be an advocate in both.
Absolutely.
And the encouragement to medical students and junior doctors is, whatever rotation you're in, whatever hospital you're in, whatever you are interested in, find a way to make a difference.
So I think, you're right, Simon, and that has to do with an approach, and I think it's also about being open. And most of us go into medicine, I would hope, to so-called help other people. Yeah. Besides ourselves, it's lucrative for us too. We will never starve. We will always be able to support the people around us who we love, and we have commitments to support. So
that's a privilege.
It is a privilege, and it's a gift. It's also a gift that sometimes we look the gift horse in the mouth when our patients want to tell us what's really bothering them. And I think that the only way you really can become an advocate is to listen to what your patients are telling you. So if there's no food on the table and you're trying to explain a diabetic diet or the DASH diet, and you ask, well, so how do you think that's going to work for you? So this is the gold standard. This is what we're telling you. But it's like, and you don't necessarily have to ask the question, but you have to really, and I think these are the skills that family medicine brings to the table around communication, is that by privileging not what you have to tell your patient, but what your patient has to tell you. And then, wait, this is Osler haunting me. I actually did a presentation on my hauntings.
Is that available on YouTube or anywhere?
No, I did it for a kind of humanities and medicine. It's a slide presentation. I'm not very good about building social media. So if there's anybody out there who wants to help me, do a kind of social media website, I'd welcome that. But that I've been haunted really by different ancestors in some way in my medical journey who try to keep me on the right path. So what Osler said is that you really don't, all you have to do is listen to your patient. And I think that we've lost that. We interrupt our patients. The average length of we allow a patient to talk is 8 seconds before we interrupt.
Wow.
So what I'm saying...
I'm feeling extremely guilty for interrupting you now.
No. You can interrupt. I give you permission. I'm not your patient yet. But I think that if we listen to what our patients are telling us, that will guide us. And that's what I'm talking about in terms of the power of our positionality in society. Yeah. And we've heard, different doctors doing that, and sometimes in this country, but all over the world, really, at their own peril. But I think it's important to speak truth to power, and it's very scary to do that alone. But there are organizations, whether formal, and then you can also, put your own group together of informal learning networks or sounding boards or people where you have common cause, and you leverage that. And there is a long tradition of health activism, in South Africa, and also a long history of backlash and intimidation.
You mentioned some of your hauntings. If you look back over, you've been in South Africa for 20?
No, I've been in South Africa. My first trip was in 1980.
1980.
And then we came back as a returning exile family in 1991.
Oh, wow. Okay, we're going to need to unpack that a bit. A returning exile family. What do you mean by that?
So there were a lot of people who left the country who were banned or house arrested or in prison, and many of them escaped. And depending on the time period, some people fled the country without documents, and earlier than that, some people left the country on an exit permit.
And were your family part of that?
Yes. So this
this is fascinating.
So
I didn't know this.
Yes. So my life partner, who became my husband, had been banned and under house arrest in South Africa as a student activist in the 60s. And so when we met at Sussex, this became that journey of how I landed in South Africa. So we were very involved in anti-apartheid activities outside of the country.
This is wild. This is very interesting.
Yeah.
Sure.
So that's the sort of tradition. And we hosted many people at that time, South Africans of all progressive political persuasions, to come and educate Canadians, British people.
So returning to South Africa in 1991, was that always a goal or a dream of yours?
Always. I mean, yes. I mean, it was his dream always. I mean, he left involuntarily. It was either that because he had broken the banning order and the house arrest order to go to prison, or at that stage in 1968, they had given him an option of leaving on an exit permit. But he was stateless when I met him. Wow. And he was traveling where he had a UN travel document, which was a piece of paper with a black and white photograph stapled onto that.
Wow.
And which allowed him entry which allowed him to return to the UK, to England, because that's where he was given political asylum.
But it's not the same as a British passport.
No.
I'm sure he had lots of experience, difficulties at border patrols.
Absolutely. So it was valid for all countries except for South Africa. So when his mum died and he applied, on compassionate grounds to return to South Africa to attend his mum's funeral, he was actually said, okay, the response from the Justice Department was, sure, you're welcome to come. But be prepared to get arrested at the border.
Wow.
So hard choices. And, again, this is why I return to principles.
Yes.
It's kind of like, what will guide you?
It must have been so emotional for him to return, hey?
Yeah. So in 1991, it was a very big emotional return, a homecoming. Very powerful.
What was it like for you, having been, you were born overseas?
Yes.
But then hearing everything and educating others on South Africa, and then now finally to come to South Africa.
Right. So I had come alone by myself in 1980 to meet the family, because they really didn't have the means to, he had a very modest, less than modest upbringing, in a poor South Indian group area in the south of Durban, actually a very industrial area, very close to the airport, the former airport. So I went and stayed with his family. I was here for 8 weeks, so I had probably for 6 of those weeks I stayed as a medical student with my in-laws. And kind of rotated between households, but it was an extended family structure. So some of it was familiar in 1991, and of course a lot of it wasn't.
Yes.
And I guess shifting a little bit from the personal to the professional, by that stage I was already well established at McGill on faculty as an academic family physician, only to come to South Africa in 1991 and not being able to practice my degree. So they had made provisions for the returning exiles, so predominantly men who had trained in Cuba, Algeria, the former Soviet Union, Poland, East Germany was another big one. And they made provisions, meaning they, the Interim National Medical and Dental Council, to reabsorb those South Africans who had studied medicine abroad, but they made no provision for their spouses, who were their classmates, who were citizens and originally from those countries, that they met and married there. So,
what was the reasoning behind it? Just purely political?
I still don't know, because they were able to, depending where they were in their studies, they were able to come back and do supervised practice for 6 months in community service and supervised public practice. And then they were able to get registration as independent practitioners. So when I came in 1991, we were repatriated through the International Organization on Migration. At that stage, we'd had 2 kids who were born in Canada. So we legally had the right to be here, myself and the children. Husband regained his South African citizenship. He had indemnity for having transgressed the Suppression of Communism and Terrorism Act. So they were granting indemnity. So he regained his citizenship. Therefore, the kids got their citizenship, and I also had the permanent residence. But there were no mechanisms to absorb me as a really highly qualified, probably at the top of my game.
You were a member of faculty at a medical school.
Yes, at yes, and teaching medical students and residents, and incredibly engaged, even nationally in Canada around the exit exams, the College of Family Physicians. So there were just a lot of So it was very difficult for a long time to figure out what to do, and at the same time lobby, because there were about 250 of us who were in that position. But at that time it was really tricky, because the SAMDC, the Medical and Dental Council of South Africa, was amalgamating with the former Bantustans. Each Bantustan had its own medical and dental council. And at that stage, when the country was going through this reunification process, they actually deported doctors who had been working in the Bantustans from Bangladesh, from Sudan, from India,
Deported them back to their countries.
Deported them back to their countries because it was now South Africa that they were going to practice in. And given that there were no mechanisms to determine competency, they sent them home.
Wow.
And so with the exodus of the military, the South African military the defense force in these areas, which I'm not sure how or why, but did provide some kind of medical services, probably in extremis, because of compulsory
national service.
National service. So there were these areas remotely, rural areas that were served, and then there were, of course, the mission hospitals, and then there were these foreign nationals who were practicing in the Bantustan, some of them in the Transkei for 25, 30 years, Ciskei. So then we petitioned for the right to write exams like any other, I was going to say civilized, but modern country, modern democratic, country where, of course, people move, there is migration. And so, set the exam. And so I was part of that first cohort eventually in 1997 that had to re-qualify as medical doctors. Wow. In South Africa. And that now has become a kind of established practice through the HPCSA. But out of, again, about 200 of us who wrote, there were 11 who passed. Wow. And there were about 30 who were able to go from, and you think you guys have it badly now. It was the first time in my life that I wrote an exam with negative marking.
Yes.
And that was in 1997. So, and I qualified in 83. So that was, a long time after basic medical school.
This is extremely fascinating as a junior doctor. Now, I was alive at the time that all of this was happening. I'm sure most of our listeners were not alive. But it's fascinating to hear the transition from one government and one system, one worldview to another. But the small nuances and the small areas of fallout and how this affected so many areas of society and so many highly qualified professionals who really just wanted to do a good job.
Right.
And really just wanted to help people and cared about their patients.
So, Simon, people go into medicine, I think, thinking, I don't have to deal with the politics. But medicine is actually nothing but politics. What drug gets approved, how and where around the world it gets distributed, what does it cost, access to technology, anything from health information, medical records, to technologies to do robotic surgery, or simple technologies, even like vitamin A drops. So, it's and unless I think our doctors, young doctors, realize that, they're going to be in for a huge, rude awakening. And they will never find peace, really. Wow. Because, everywhere you turn, whether it's micropolitics, and I'm sure a lot of your listeners, as well as I do, indulge sometimes in these medical shows. So whether it's about, internal politics within a hospital, about who's going to be the next chief of surgery, or
even who gets to roster
yes,
who's on call
Christmas, and when you're put on call, exactly, and the trade-offs, how
yes.
you get around that.
Yes. That's the micropolitics, but then it's every level.
It's at every level. So, you cannot be a doctor, especially I think in today's society where there's just such, disparities in the way and how medicine is practiced. And this is around the world. You cannot avoid that. So you really have to, I think, go in and be prepared for that, but also learn those skills about dealing with power and stepping also into your own power in a responsible way, and really leveraging that, to do good for the right cause and for principles that are bigger than yourself.
At the beginning of this interview, I said that the primary focus of the interview would be about the road to specializing in family medicine and, what the path is. But I'm so glad that you have come across on the podcast, because this has actually turned into a conversation about all of the things that you're passionate about: patient rights, how we can best engage, all of the different resources in our system, how we can be advocates for change. I think the topic of this podcast has shifted away from family medicine to what every single young doctor needs to hear: how we can best serve our patients and how we can best, in summary, how we can help people.
Yeah.
So in closing, to just frame this podcast, is there any one final thought or closing thoughts that you'd like to give to junior doctors? Something, it can be an encouragement, it can be a correction if we're missing out on something, if we deserve a smack.
No, I'm although I do believe in tough love, I'm more of the carrot rather than the stick, because I was trained in a very anxiety-provoking medical context at the time that I trained, and I wouldn't really wish that on anyone. And I think maybe, part of my mission has been corrective also around medical education and giving support and really encouraging maybe caring for caregivers and caring for ourselves in that process, because we won't. My late mother always used to say, Laurel, you want to get out there and save the world, but you're not going to be good to anybody if you're burning the candle at both ends. So really, I think we need to take care of ourselves, our own health, and that includes mental health, emotional health, spiritual health. And I think we also have to, cut people some slack. The world is not a perfect place, and I think that setting your intentions, to do the right thing, for yourself and for others is, I think, a really good place to start. And I think kindness, is a value, and I think maybe trying to decide what you stand for as a person and what your values are, and revisiting those from time to time is really important. So, and I think the other thing is that if we really care about health, health is actually not the end point. Health is a means for us to be able to do other things in life. And I want to refer people back, to the Ottawa Charter as opposed to the WHO definition of health, which is okay, which is the complete state. I don't know if anyone ever attains the complete state, but I think the Ottawa Charter, talks about, that health is a resource for everyday living. So it enables us to do lots of other things. And I think when we're with our patients, we need to understand that. And also, we need to understand the limitations of medicine. And I think if we fixed a lot of the what's now called the social determinants of health, so again, going back to my own roots in Kentucky, why generations of young men went down into the coal mines and got black lung, like why was that their only option for work, for example? Or the same thing with tobacco. Why is growing tobacco the only option that many people had? And so I think that thinking about root causes, making sure that everyone has a dry roof over their heads and that they have enough food in their belly and they're able to send their kids to school and they're able to actually themselves do something that gives them a sense of dignity. And as doctors, I wouldn't want us just to confine our engagements within the four walls of a hospital or a clinic.
Professor, it has been an absolute pleasure to have you on the podcast. You're a wonderful human being. Thank you for all of your input into our audience. I hope that we can get you on again to speak about the issues that interest you and that you feel passionate about. But thank you from the bottom of my heart. Thank you.
Okay, thank you, Simon. Thanks for the opportunity.
I hope you enjoyed this week's episode as much as I did. If you know of a consultant or senior registrar in a specialty that you would like featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks.